Great, thank you, Abby. Can you all hear me? Yeah. You all good? Okay. Firstly, I'd just like to thank Louise and Javier for inviting myself and Yedra and Steve over. It's been a great couple of days and really enjoyed your hospitality. It's been a great meeting and I hope that what I'm going to talk to you about today will be of interest. The purpose of the talk is really to cover work that we've been doing over the last couple of years, examining great ape cardiology. It started somewhat serendipitously, just with a conversation that I had with Yedra and her colleagues at London Zoo, and it's grown quite rapidly over the last couple of years to the point now where we've assessed probably close to 50 animals in the last 2 years, and certainly over the next 12 months we want the project to grow considerably, and it would be very interesting to get your input to what we've done so far and any ideas that you've got for us in terms of our development. We have got 2 hours scheduled. I'm not sure I've got 2 hours worth of slides, I may do, but if you have any questions, either because you don't understand what I've said from a technical perspective, or if I'm talking too quickly in English, and I apologise that I can't deliver this talk in Spanish, but unfortunately I really can't speak any Spanish other than ordering 2 beers. So please feel free to stop me and ask questions as we go along. In the schedule, it is scheduled as 2 separate talks. What I've actually done is put it all together, and we'll stop at a number of points along the way. And if you've got any questions at those points, please again feel free to ask them. First thing I like to do with the presentation is to provide the take-home message. So if anyone wants to just go to sleep or listen to some music, this is what we're going to end up with at the end of my talk. Cardiac disease is likely a problem within great ape populations. I think there's some literature out there which really says that it is. I'm not sure we can be that convinced at this point in time, but I think likely a problem in some populations. As in human cardiology, there are a number of tools that can be really, really useful in terms of diagnosing, treating, and also managing disease within populations. And the 3 that we're going to really look at today are echo, or cardiac ultrasound, ECG, so the electrocardiogram, or maybe you are aware of it as the EKG, either works for me, and then cardiac biomarkers. There's a number of blood-borne humoral markers which are really reflective of cardiac health. And I think these could be very, very useful tools in terms of understanding cardiac disease in great apes. In human cardiology, there's clear diagnostic criteria. Unfortunately, in great ape populations, we do not know what a normal heart looks like in a chimpanzee, in a bonobo, in a gorilla. We simply don't. And if you go to the literature, a lot of the work references back to human normal values. Now, to me, that's just nonsense. You know, we have a human individual, maybe a small female, 50 kilograms, and we have normal values for that person. To translate that into the 220 kilo silverback gorilla is frankly ridiculous. But it has been done in the literature. So we do not have diagnostic criteria at the moment, and that is something that we are going to work towards over the next few years. We're trying to establish protocols, so not only are we looking at the diagnostic criteria, but we're actually trying to establish how to undertake a cardiac examination in great apes. And we've got a paper at the moment that is in the last stages of production, and hopefully that will get submitted fairly soon in terms of how you undertake a cardiac ultrasound. So that is the take-home message. If you want to go to sleep now, you can. Otherwise, what I'm going to hopefully try and do is walk you through all of these over the next hour and a half or so. Please, please feel free to ask questions as we go. So this is the structure. I'm going to give you a little bit of background of the project and a little bit of background of myself, because I'm slightly unusual here in that typically I don't deal with animals. It's only over the last couple of years that I've been working with animals. I'm a human physiologist normally. We're then going to look through each of the sections of the cardiac examination: echo, ECG, and biomarkers. And at the end of each of those descriptions, we'll pause and deal with any questions. I'm then going to present 3 or 4 case studies of individual animals where we've got some very interesting data, and perhaps I'll get you guys to give me some interpretation or your impression of the data I show you, and you can let me know what you think about it. Then there's a little bit of preliminary data in terms of grouping all of the numbers together, which is beginning to show some very interesting trends, but I can't really say that it's anything more than trends at this point in time. And then just I'll touch on future directions for the project at the end. So, my day job. Typically, I'm dealing with these kind of characters. So, for a number of years I've worked for the British Olympic Association dealing with athletes, giving them advice on how to train, and then also looking at the effects of different types of exercise upon the cardiovascular system. And we know that certainly the cardiac adaptation we get to this type of exercise training is very different to the type of adaptation we get to resistance type exercise. And that was my background, and one of the interests I then had is, okay, how have we as humans ended up with the heart and indeed the whole cardiovascular system that we have? And that's what initially took me to speak with Yedra and Kai at London Zoo. I'm also very interested in the role of exercise in managing cardiac disease in humans. So you're probably all aware of cardiac rehabilitation following myocardial infarction, following a heart attack. People go through an exercise prescription, and that has a very positive effect upon the heart. And how do we know that it has a positive effect on the heart? Well, we can look at the heart using ultrasound, we can look at biomarkers, we can look at the ECG, and we can tell that we've had a positive effect. And it's those tools that we're now using within the Great Apes Heart project to understand what's going on, valve integrity. So, positioning. And I cannot emphasize the importance of getting the position right in terms of a cardiac exam. In the human world, we get people and we put them on a couch and we tilt them 45 degrees. What that does is it brings the lung out of play, and it gives us a much better window in through the chest wall, allowing us to get a good image of the heart. So we try to do the same with the animals. And here we've got an example up at Chester where we have one of the keepers, I think this is Neil, who is supporting a chimpanzee during an assessment. So the chimpanzee has been put on a couple of bales of hay, which is really helpful because it just lifts it up and it allows us to get in nice and close to the animal. And then Neil is sat behind the animal so that we can tilt them to about that 45-degree angle. Sometimes use a foam wedge, sometimes use a sandbag, use whatever you can, as long as the animal is stable. That then rotate the chest over, the lung falls out of the way, and typically you get better images. However, that's not always possible. If you've got a very large animal, Neil would have to be very strong to hold a 220 kilo silverback. But if you can tilt them, great. But if you can't, it's still very much worthwhile trying to get images just in normal dorsal redundancy. And we've done quite well in acquiring some of the images. You don't always get a full data set, but you can certainly get some images that are quite useful. The other thing that I want to mention at this point in time is that within the human world, we get people to exhale when we take the images. By getting the person to breathe out, what that does is it keeps the intrathoracic pressures fairly stable as you're acquiring the images. And what that means is that the heart doesn't swing. And you'll see in some of the images that the heart is actually moving, and that's related to the respiratory cycle and the changes in pressure. Unfortunately, we can't get the animals to hold their breath, although the first time we did an examination, Eric did go over and say, can you actually hold your breath? And again, forgive me, you probably are all very, very familiar with this, but it's just something that I need to remind you of, is that it's important to know which side of the probe you're looking at. And all of the probes either have a light on them or a ridge on them which shows which side of the probe reflects which side of the screen. Because it can be quite easy to have the heart around the wrong way, and you think that looks strange, and then you realise, no, you've just got the probe around the wrong way. So just a reminder to bear in mind, and when you look at all of the screens, there's usually a light at the top which just identifies which is left and which is right, and that light corresponds to either the light or the ridge. Forgive me if that's obvious. So these are the windows that we use. We use a parasternal window, and we use an apical window. These allow us to get a number of views of the heart from different angles. Occasionally you might use a subcostal view. We haven't really focused on that with the Great Apes. My personal belief is that we can't control their breathing. Also, that the apes can be quite muscular here, and I'm not sure we're going to get that good an image. In humans, you use it really to look at the right side of the heart, and with some of the other windows you can get quite a decent image of the right side of the heart. So we haven't tended to look at this as of yet, but we may well do as things advance. The other thing that's been quite interesting for us is that the parasternal window in the apes, and especially the large gorillas, is a little bit further up towards the head. I think that the heart sits a little bit higher in the chest wall than it does in humans. These are very much guides. So if you get to the point where you are undertaking these examinations and you look at these slides and you go, Rob said I need to be here. Well, okay, generally around that area is fine, but then try and move around and try and optimize the image based on what you know the image should look like rather than the anatomical position in terms of where we say to actually take the exam. Often, when I get papers to review, I see an image that's been taken, and it's the example image from a study. And the number of times you see an image that hasn't been optimized. And what I mean by optimization is that ultrasound is using, if you think that there's ultrasound energy being emitted from the probe, a lot of that time, sometimes that energy can be wasted if the image isn't optimized appropriately. So whatever you're interested in, so it might be the septal wall or it might be a valve, get that in the middle of the screen. And don't have lots of wasted space below it. If you can get what you want in the middle of the screen and not wasted space below it, you know that you're using as much of that ultrasound energy as possible to get the best image of the area that you are interested in. Don't over-gain images. Often people put the gain up and it's really bright, but actually what you really want is really clear definition. You want a black blood pool. The inside of the ventricle ideally should be black and the walls are nice grey. And also make sure that you get the depth adjusted appropriately using some of you've got the overall gain, but you've also got the TGCs, the individual gains. Try and use those. Often people are scared of an ultrasound machine because it looks like a really complicated computer with lots of knobs and dials. Be prepared to spend a little bit of time trying to optimize your image, and it'll make a huge amount of difference to the data that you get. So, this is a parasternal image, so we're right on the sternum, and we get a long axis view. This long axis view gives us a nice image of the interventricular septum, the left ventricular cavity, the posterior wall, the left atria, and the aortic root and aortic valve. You can also get a little bit of the right ventricle here, but this is the standard starting point for a cardiac exam. Parasternal long axis. In this view, sorry for a complicated, or looks like a busy slide. In this view, you can actually then sweep from the base of the heart, so at the mitral valve level, through the ventricular length. And you can move from the base to the mid to the apex, allowing you to focus in on what is of interest. So if we take something like hypertrophic cardiomyopathy, that might not affect the entire ventricle. It might just affect a small section. So have a thorough look, and that's what I'm hopefully trying to talk you through today, is a systematic approach to a cardiac examination. There may be areas that are more prone to disease that you might think the animal has. So be prepared to move through the ventricle to have a good look. And what you can use is the the M mode modality. So remember, that's the cross section through against time, and then you can swing that M mode from the base all the way through to the apex, and indeed further up the heart, so you come through the aortic root and the left atrium here. So in some of the literature, there was suggestion that gorillas suffered from aortic dissection. I'm not so sure of that anymore, but this would be an image that you may use to look at the aortic root, to look at the thickness of that aorta. But again, what I'm trying to do here is show you that yes, you can get an image, but then you can focus in on specific bits of it to get more information. Don't just be satisfied with, okay, I've got a good beam mode image. Make sure that you're actually looking at different sections of the heart. So, from this parasternal long axis, so I've got the transducer on the chest wall, the light at this point is pointing towards the animal's right shoulder. We then rotate the probe 90 degrees. And that 90-degree rotation takes us into the view that's called the parasternal short axis view. And this is a view that's looking down on the heart. We're looking from the base down through the mitral valve, down towards the apex. Sometimes looks like a goldfish mouth. If you're in the right level, you see the valve opening and closing, similar to a goldfish mouth. And in a nice healthy heart, you have this donut shape, this perfectly circular ring of the left ventricle, and you have the right ventricle wrapping around the LV. From here, you can look at the valve motion, you can look and see how well the heart is contracting. You can also look at thicknesses, so you can look at ventricular septal thickness or posterior wall thickness. The diameters of the walls are often taken from this image, but sometimes, and don't be afraid to do this, you get a better, clearer, short axis view than you do a long axis view. And there's nothing wrong with taking wall thickness measurements from the short axis as well as the long axis. Does that make sense to people? Are you happy with that? So, I talked through the long axis view, where we swept from the base down through the apex. We've now rotated around into the short axis view, and we can again, so we've rotated round. Now what we can do is tilt the transducer. By tilting the transducer, we can look from right up the pulmonary artery or the aortic root view all the way down to the apex of the heart. And you see here's the transducer, and as we tilt it, we move down through to the apex. Now sometimes, so you've rotated around in parasternal short axis view. If you're interested in the apex, you may have to move down the window, move down a rib space, so that you're actually coming through the heart. You've got a nice perpendicular cut through the heart, and you're not on too much of an angle. So again, that's why I said right at the beginning, don't get too hung up on what I've said in terms of you need to do it in this way. You will see whether you've got a good cut or not. And if you don't think you have, don't be afraid to move down a rib space to try and open up the acoustic window and get the appropriate cut through the heart. Yeah. So, parasternal long axis, parasternal short axis, really very useful for wall thicknesses. In terms of overall function, the ejection fraction that I mentioned is something that is often looked at, as is stroke volume. The recommended way of getting ejection fractions and stroke volumes is from a 4-chamber and 2-chamber view. So this, you take the probe off and you now come to an apical window. So you're looking from the apex of the heart up to the base of the heart. We have a 4-chamber, we've got the left ventricle, somewhat confusingly on the right side of the screen, the right on the left, and obviously the atria above, but actually on the screen below. Again, if we rotate the transducer 90 degrees, we end up getting a 2-chamber view as well. So this is looking from the septal wall to the lateral free wall, and this is looking from the anterior wall to the posterior wall. This therefore gives us a two-dimensional cut through the heart. And from this we can then generate much better estimates of overall volume. So we can look at diastolic volume, we can look at systolic volume, and from that obviously we can calculate the stroke volume and the ejection fraction. This is a relatively easy image to acquire. The two-chamber is difficult. If you can't get a two-chamber, don't worry about it. You can get very useful information just from the four-chamber view. This slide presentation will be available, so in terms of the images, you'll have access to them if you're interested. Again, a very, very busy slide, but this gives you an idea when you start combining all of those cuts together, the sort of information that you can get. So here we have a four-chamber view, here we have a two-chamber view, here we have the parasternal short axis at just the papillary muscle level, here we're going down at the mid-level, and here at the apex. So those different views from an initial position that we then rotate. We get the long axis and short axis, we then come to the apex, we get a four-chamber view, we rotate 90 degrees, we get a two-chamber view. All of that information gives us an overall view of what's going on in the heart. And remember that different pathologies may affect certain areas of the heart more than others, and it is important to try and cover as many areas of the heart as possible so that you have a thorough understanding of what's going on and you can be confident in what you're seeing. Okay, so here's just a slightly more detailed view of the M mode through. So we get the nice B mode parasternal long axis. We try and put our cut, our M mode, nice and perpendicular through the heart. If we're coming on a slant like this, any measurements of wall thicknesses will be off. Yeah? And you certainly don't want to say you're running an examination and you get your cut wrong and you measure your septal thickness. You might get it at 12 millimeters might be what it actually is, but if you don't have a perpendicular cut, it might be 14 millimeters. That all of a sudden starts to look more like a HDM, a hypertrophic cardiomyopathy type heart, rather than a normal heart. So getting that cut right is important. So we have septal thickness here during diastole, and those are typically the measures you want to report. So septal thickness during diastole, internal diameter of the ventricle during diastole, and the posterior wall during diastole. You can also measure during the systolic period, and you can use those measurements to estimate, using a number of equations, you can estimate ejection fraction and stroke volume from that, but it's not the recommended. And if you want a good set of guidelines for echocardiography, the American Society of Echocardiography produce a huge number of documents that are really, really useful. They also produce some really, really good posters that are teaching aids in terms of how to get the cuts appropriately. So really worth a look on their website if this is an area that's interesting to you. This was Steve and Yedra last night talking about function. Yes, it was last night. Yes. You've got to be on the ball. I wasn't there at all. I wasn't there at all. This is last night. Okay, so I just want to pause there. There's a lot of information there. Some of it might have been recap, other bits might not have been. So I'll just pause there. Any questions initially on cardiac structural assessment using ultrasound? Why? Anything? Or are we okay? It's fine.
You need to do always the same mode to have the same information.
Okay. Great question. And this is a conversation I've had with the American group. So America's obviously huge. And so there's different people taking the images. And so you have to follow a standard protocol to be able to compare across animals, or indeed between the same animal. So if you do the same animal a number of times, which you may well do if you're looking at disease progress, you've got to make sure you're in the same place each time. And so that following a standardized protocol is absolutely, absolutely critical. Ideally, with the same sonographer. So if you and I both do a cardiac exam, we'll probably do it slightly differently. We'll try and standardize, but we may well do it slightly differently. So standardization is absolutely critical. And that's why it's important to also make notes during your process. So you might think, okay, I've been here for a few minutes and I just can't get a great image. Well, store that image anyway and use it, but make a note and say, okay, I didn't get a great angle, just so that if you or the next person comes back. So here we have the 4-chamber view, so this is the left ventricle, and here is the left ventricle, but the 2-chamber view. We use what's known as Simpson's formula, and what we do is we roll the image to end diastole. We then trace the endocardium. Yeah? We trace between the wall and the blood pool, and we get the end diastolic volume. We then roll the image through to end systole and do the same, and we then do the same with the 2-chamber. So we get an end diastolic volume and then systolic volume, and that allows us to get stroke volume and ejection fraction. And that is the recommended way of doing or of assessing stroke volume and ejection fraction. That's nice and soothing, Steve. So, this is a healthy male chimpanzee. So what do you see? Talk me through the 4-chamber view. What are the characteristics of that video? What do you see? Cool. Okay, so the cut's not bad. We've got most of the left ventricle in. Unfortunately, you don't get too much of the right ventricle from this view. But what do you notice about the tricuspid and the mitral valve? They're both moving largely together. There's uniform movement through the cardiac cycle. If we look at the myocardium itself, so if we look at the septum and we look at the free wall, they're moving together. Yeah? As one area contracts, the other area contracts. We see nice uniform movement here. If we look at the long axis, we can see the mitral valve opening very nicely. We can just about make out the aortic valve opening nice and clearly. And then when we come to the end mode through the LV, or indeed through the aorta in the left atria, there's nice movement. Both walls are moving together during systole and diastole. And I want to show you the healthy one before we go on to ones that might not look so healthy. But you can see how the heart is moving nicely together. And the more you do these in these exams, the more you pick up what looks normal and what may be potentially abnormal. So that was systolic function. I mentioned diastolic function. The key measure of diastolic function is the early to late ventricular filling ratio, or the EA ratio. If we get a good, I'm going to go back a bit. If we get a good 4-chamber view in our D mode modality, we then put on the pulse wave Doppler modality, and we put the cursor just below the mitral valve about here. That will then generate a flow profile that looks something like this. And we have early ventricular filling and late or atrial filling. So you guys are probably aware there's 2 phases of filling within diastole, or typically there is. We'll move on to something a little bit later which might not look like that. But the early filling represents pressure decay in the ventricle during early diastasis, or during early diastole rather, and pressure increase in the atria. When pressure in the atria is greater than that in the ventricle, the mitral valve opens and we get nice early filling. In healthy individuals, that is the dominant source of filling. Probably 80% of ventricular filling occurs during early diastole. Then we get an atrial contraction, which just kind of tops up the filling in the ventricle. The ratio of that E to A is an indication of how well the heart is relaxing. So if the heart isn't relaxing very well, if the heart is stiff, if the heart is fibrotic, if the heart is aged, what happens is that the early filling reduces and the atrial filling increases. The filling from the atrial component increases to compensate. And so we get a reduction in the EA ratio. So if we've got a fibrotic heart, it is highly likely that the ratio changes. So anything above 1 is considered normal in humans. Typically within athletic individuals or younger individuals, it's 1.5 or above. So that demonstrates that there's a real dominance of the early aspect of ventricular filling. Okay. So does that EA ratio make sense? Yeah? Cool. I'm not going to go through this, but I've put this in here so that you can look at it. These are the human criteria for the progression of diastolic disease. So as diastolic disease becomes worse, we move down this continuum. I'm not going to go through it. There's other modalities used here as well. But if you're interested in diastolic disease, it's certainly worth a look at this figure. And I've mentioned the American Society of Echocardiography already, but these are the most recent guidelines from 2005, I think, written by Roberto Lang, looking at overall structural quantification of the chamber. But there are also a couple of key papers that are looking at diastolic function and the assessment of diastolic function. Again, it's human cardiology, but human heart's probably a lot closer to apes than some of the other animals out there. So please feel free to look at those. Yeah, I can't really give you those because it would be contravening copyright, but at least you've got the references so you can go and find them. So tissue Doppler, it's a relatively new modality. Most modern machines have tissue Doppler on now. And this, as I mentioned, looks at the velocity of the myocardium. So if you have an area of the heart that's not working so well, you can pick it up very nicely using tissue Doppler. Now, similar to standard Doppler, it's looking at velocities. You get a good B mode image, 4-chamber B mode image, and then you put your cursor either on the lateral free wall, the septal wall, and in this modality you can also come across here onto the right wall and look at individual velocities. And you get velocities during early diastole and late diastole. In any literature, those are referred to as E prime and A prime. And you also get a systolic velocity as well. This can be really, really useful to look at overall function, and indeed we combine the data from the septum and the free wall to give us a global indicator of myocardial velocities. Interestingly to note, the right ventricle is often much faster than the left ventricle. So if you run an exam and the right ventricular wall is moving at a similar rate to the left ventricular wall, you might think that there's actually something of a right-sided issue going on. So again, this allows us to start compartmentalizing the heart and looking at it in much more detail than has historically been done. And what's the other really good thing about tissue Doppler is even on really poor images, poor B mode images, you can often get a really good tissue Doppler trace. So if you've got an exam, maybe it's an unstable anesthesia, maybe there's some pulmonary issues, and you've not got a great 4-chamber view, still have a go and try and get the tissue Doppler on there because you might get some really useful data from it. Okay, valve disease. This is we use the colour flow mapping to assess this. So, you're probably aware of this, but in terms of looking at blood flow, we use the convention BART, B-A-R-T, that's in English, I'm not sure what it would be in Spanish, the other blue away, red towards.
El azul se aleja y el rojo se acerca.
Thanks. So, in English, it's blue away towards and red towards. So anything coloured blue is blood flow, or indeed myocardial movement, moving away from the transducer. So if I have the transducer at the apex of my heart, during systole, there's blood moving out of my aorta. I'm going to see that blood flow out of my aorta in which colour? Blue. Okay? And during diastole, I'm going to see blood flow into the ventricle, and it's going to be red. If you have an idea of the normal physiology of blood flow through the heart, you can use colour flow mapping to see whether there are any issues going on. Then we have the colour, and the brightness of the colour. If the colour is very, very bright at either end, it's fast moving blood. If it's not so bright, it's a lower velocity. So, what have we got here? Anyone see anything interesting? A heart pumping. Anyone see more than a heart pumping?
There's some mixture. He's getting a flash of yellow in so
Okay, so let's just talk through a little bit. During systole, we're expecting a big blue flash out of the ventricle, yeah? So if you look here, that blue that you see periodically is during systole, that's blood moving from the apex of the heart out towards the aorta that's situated about here. Yeah? Then during diastole we have a big red, well it's actually yellow and then red flash. That's high velocity blood moving into the ventricle during diastole. Yeah? During systole, we see this big blue flash. There's also a very small jet here that's a bright colour. Yeah? What we've got here is a bit of regurgitation of the mitral valve. That flash, a bright flash of light that you see there, that is a little bit of regurgitation. Regurgitation is a little bit difficult to quantify, and it's often seen, and often it's physiological in nature. It's when you get larger regurgitation that it becomes problematic. But you can see how using this technique, we can see that this valve, there is a little bit of an issue with it. Okay, so that's the mitral valve. This one's much clearer. So this is regurgitation between the RV and the RA. Can you see that? Big, bright flash, blue flash, moving back from the ventricle into the atrium during systole, going in the wrong way. Not ideal, and we'll come back to this case a little bit later. Okay. What do you see in this one? Anything? You know, I mentioned the respiratory swing early on, where we can't get the animals to exhale and hold their breath, and so the heart moves around quite a lot. This four-chamber view, you can see right at the beginning there's a lot of movement going on. That's not ideal. Really, you want it nice and still. But it's still quite a clear image, and what you can see is that the walls are moving relatively well together, and when we look at the M mode, relatively clear. There's no regurgitation on the mitral valve here. This actually is just a very healthy, asymptomatic bonobo that we assessed. Now, in humans, one of the challenges that we use, if we think that there might be some disease, we get people to do exercise, and we assess the heart during exercise. I didn't think this would be possible in Great Apes, but I did find this image online, which gives That it isn't possible to get apes to do some exercise. Okay, so that's echocardiography. We'll pause there for a minute. Again, any questions, please ask. Have a sip of water before we move on. Anything at this point? Some of the start of the talk. We spoke about congenital and acquired. The focus of the work in this area has really been around cardiac ultrasound. And I can see why, because it's very nice to do it and you get some great images. But interestingly, from a human perspective, the first diagnostic tool of choice is typically the ECG. It, in the hands of the right people, it probably is 90% diagnostic, whereas actually the ultrasound will just look at structural disorders. So if we're interested in something like long QT, or indeed hypertrophic cardiomyopathy, those indices of that disease will be picked up on the ECG if you know what you're looking at. So what I now want to do is move on to the 12-lead electrocardiogram. Used to look at arrhythmia, used to look at ischemia, overall enlargement can also be picked up on the ECG. And it's useful for both congenital and acquired disorders. But similar to the echo data, we don't have any standardization in terms of, not so much standardization, we don't have any normal reference values at this point in time. So these are both gorillas, but we've been able to do this on right down to small bonobos. You can get neonatal ECG electrodes, so you can get onto quite small animals as well. Again, you're probably all very, very familiar with the ECG, but just a quick recap. We have a P wave, which is related to the electrical activity of atrial depolarization. We have a QRS complex, which is the ventricular depolarization, electrical activity associated with ventricular contraction. We then have the T wave, which represents ventricular repolarization. But in between each of these waveforms, there's some segments, and those segments actually become quite useful and quite interesting. So we have a PR interval, we have a QT interval, I've already mentioned long QT disease, and we have the QRS complex itself. So we can measure both time, so the time it takes for the wave of depolarization to move across certain segments of the heart. We can also look at the amplitude. So by that I mean the height of these structures. So we can look at the height of the QRS complex, we can look at the height of the P wave. And within humans, we know what is normal. So we have normal ranges so that the P wave shouldn't be any longer than 0.12 of a second. We know that the QRS complex should be a certain height. If we had those diagnostic criteria in Great Apes, we could use an ECG. It's a much cheaper machine. The data is far easier to transport across using computers, and it can be a very, very useful tool. When we hit print, this is what we typically get out. This is the 12-lead ECG. We end up with the limb leads, and we have the chest leads, and we have a rhythm strip. So if we're looking for arrhythmia, we typically look at the rhythm strip, which is usually lead 2, but we have the limb leads and the chest leads. So we have 12 electrical pictures of the heart. And those 12 electrical pictures come from different angles. So if we look at the limb leads, they go from the top of the heart to the bottom of the heart, looking at electrical activity from the top to the bottom. If we look at the chest leads, we go from anterior to posterior. The heart in the apes and as with humans is rotated anteriorly. So what you're actually seeing at the front of the chest wall is often the right side of the heart. So when we look at the chest leads, V1 and V2 is the right side of the heart, whereas V5 and 6 is typically the left side of the heart. So again, understanding your anatomy and understanding the different leads that you get from the 12 lead means that you can look at different angles or different aspects of the heart using the 12 lead ECG. And similar to the echo, by combining all of these together, we get a holistic view of what is going on. So, one of the things we can calculate is the mean electrical axis of the heart. Typically, it runs, and again, this is from humans, we don't know what goes on in the great apes at this point in time, but typically in humans, the mean electrical axis runs from the right shoulder to the left hip. So therefore, any leads down here, you'll get the most electrical activity. You'll get the biggest QRS complex in a lead that's positioned here. But this purple range here, from -30 to +105, that's the normal range. So it's quite a large normal range of where the mean electrical axis of the heart lies. If it's outside of that, it's indicative that there may be something wrong. At the moment, we don't know what that normal range is in any of the apes. In humans, we use what's known as the Sokolow-Lyon criteria as an indicator of left ventricular hypertrophy. And what this is we take the R wave in V5, so we measure from this point to the peak, that's the R wave. So here we've got 5, 10, 15, 20, probably 21 millimeters in V5, plus the S wave in V1, so down here. So we're looking at probably about 10. We're about 31, 32 millimeters. In humans, anything above 35 is indicative of left ventricular hypertrophy. Again, we do not know what those criteria should be in the Great Apes. We also look at different aspects of the ECG. So we might look for waves such as this. So this is what's called a delta wave. It's an upstroke. It's an early depolarization of the ventricles. The ventricles are depolarizing much earlier than expected. And this is indicative of that accessory pathway I spoke about earlier on. So there's a condition called Parkinson-White where you have an accessory pathway between the atria and the ventricles. That can cause sudden cardiac death. We can pick this up on the ECG. You may not see it on an echo. It's actually quite likely you don't see it on an echo. And the ECG is far more sensitive to that. So again, this is a tool that could be used that would add significantly to the standard echo. With hypertrophic cardiomyopathy, another disease and probably the leading cause of sudden cardiac death in young people, is indicated by these flipped T waves. So you end up with T wave inversion. Again, we don't know whether these exist in animals, and we don't know whether they are indicative in the Great Ape population. But certainly, if I saw flipped T waves in some of the ECGs we were taking, I would be slightly concerned. And we also have prolongation of the QT, long QT syndrome, responsible for sudden cardiac death in humans. So we start at the beginning of the QRS complex, we measure from here to the end of the T wave. This is an extended long QT here, and that may cause sudden cardiac death. So we have these criteria, but at this point in time, we don't have we don't have any established criteria names. The data I'm now going to show you are something that I'm very excited by, but it's Rebecca Atencia who's done all of the work here. And she's collected over 100 ECGs from the collection, the JGI collection in Congo. And she shared the data with me last year, and we've been working on it together. And I think this is getting close to the point where we may have some criteria that allow us to look at what is normal in chimpanzees. So these are just some of the data at the moment. So this is the QRS axis. So we calculated the QRS axis on these 100 animals. And remember, we had humans minus 30 to plus 90 is normal. So these individuals here, and I think it's about 4 or 5 individuals of the 100 on human criteria have an abnormal QRS axis. But is that abnormal for a chimp? If we look at QRS duration, so this is the amount of time it takes for the ventricles to depolarize. Again, I'm encouraged that we're seeing normal distributions here, or semi-normal distributions, because it means that I think we're getting close to the point of being able to get abnormal values. Again, based on human vet data, there are a number of individual animals that are outside the normal range. This might represent some conduction delay going through the ventricle. It might be representative of fibrosis, so the wave of depolarization is not going through so well. Or it might be hypertrophy. The heart itself is just thicker, and so it's taking longer to go on. At this point in time, we don't know. But again, there are some individuals outside. Similarly, the QT duration. So this is the time for repolarization, so the relaxation, if you like, of the electrical activity. Again, there are a small number of animals based on human values that are way outside of it. But this is the one that I think is probably the most interesting in terms of showing the ridiculousness of using human criteria on apes. This is that Sokolow criteria I was talking about in terms of what indicates left ventricular hypertrophy. And we can see that there's a huge number here of animals that, based on human criteria, would be diagnosed as having left ventricular hypertrophy. What that says to me is that actually probably the hearts of these chimpanzees are thicker, and it's normal for them to be thicker. But again, what it does reflect is that those early papers comparing using human criteria are probably wholly inappropriate. So you might not be able to see this too well, unfortunately. This is an ECG in a human. And what I really want you to have a quick look at, you can see that there's a P wave here. Where in sinus rhythm, there's a P wave prior to every QRS complex. This is an ECG, first ECG we ever took on a gorilla. And as it came through, I thought, that looks very, very strange. And there doesn't appear to be any P wave, which says that there's very little atrial activity. At first I thought, okay, what's going on here? We then looked at the transmitral filling. And remember the EA ratio that I talked about in terms of diastolic filling. Gorillas seem to have very, very little atrial contribution to filling. Why this is, we don't know at the moment. There's a couple of theories that we've got, but it's very interesting to see that the P wave amplitude and duration is very, very small in gorillas, and often you don't see it at all, which I think is certainly an interesting thing. And whether this is related to an evolutionary difference, a theory that I have is that humans have evolved as endurance animals, and so filling of the ventricle has been really, really important to be able to fuel the oxygen required for exercise, and so filling is important. Whereas gorillas, and you guys know this better than I, the activity pattern is very, very different. They're sat in a big salad bowl all day, and then occasionally a big fight, and then sit down. So they're more an anaerobic strength type animal. But certainly an interesting comparison that we found. Okay, so that's a whistle-stop tour through ECGs. I'll pause again and see if anyone's got any questions. Probably should have said the position of the electrodes is important, and what we've used is just a standard human positioning. So again, I haven't put that on there, but I can put a reference and let these guys know so you can find out how to do that. Any questions on ECG? Okay. Right. Cardiac biomarkers. This is where Yedra and Ty and I initially started conversation, because I've done a lot of work on cardiac troponins in humans. But they can be used to diagnose disease, so cardiac troponin is now the cornerstone of diagnosis of heart attack in humans. We look for an elevation in cardiac troponin. So it's a structural protein that when the heart is damaged, leaks out into the blood and we can pick it up. And we can pick it up pretty quickly at the onset of any damage to the heart. Some of the biomarkers are used for risk stratification. So if you have certain levels, it is indicative that your heart's going to fail further, or that you should be treated in a different way. Evaluation of treatment, I know I haven't actually got the data here, but Yedra's got some very interesting data from, what is it? Golden-headed lion tamarins, showing how the biomarkers change in response to treatment. So they seem to be fairly sensitive to treatment as well. Relatively non-invasive, relatively, if you can train an animal for blood sampling, you can use this. Doesn't take significant training to actually get the sample beyond what you normally do if you've got a good laboratory hand. And certainly some of the biomarkers are probably very sensitive to early changes, and probably will spike, will start to rise before you see any change on the ECG or indeed the echo. So using these tools together, I think, is what we're beginning to recommend, really. So the two we're very interested in, B-type natriuretic peptide, or BNP, and it's a measure of volume overload or ventricular stretch. So if there's abnormal enlargement, the walls of the heart will be stretched and it will be released into the circulation. And so this has been used extensively within the heart failure literature. But one of the issues with this is that it does increase in response to elevations in heart rate. So we've certainly shown that exercise brings about a huge increase in NT-proBNP. So this then obviously has implications for your anaesthetic protocol. So if you can have a very nice, calm induction, I think this measure is really useful. If there's a lot of stress involved with the anaesthetic protocol, BNP may be adversely elevated because of that. Cardiac troponin is a measure of cardiac damage or cell necrosis. The cardiomyocyte has to actually be going through the necrotic process for the cardiac troponin to be released. So this is a far more advanced marker. BNP will change sooner than cardiac troponin. If you've got an elevation in cardiac troponin, I'm far more concerned than a moderate elevation in BNP. So there are two ways of doing this. You can either get a relationship with a good laboratory. Some of the issues associated with that: preparation of the sample, appropriate transport. The sample should be kept on ice if it's going to take a while to transport. If you are transporting from one country to another, then obviously it needs to be on dry ice. This has major issues if you were trying to think about using this in some of the sanctuary populations. Obviously you've got CITES issues in terms of transporting it. And there's a significant delay before you then get the sample to your friendly scientist in the lab, who can then run the assay in the laboratory. Okay, so there are some issues with laboratory assessment, but there's also some pros to using a laboratory. You know that the scientist in the lab undergoes really good quality control processes of the machine. Often, the laboratory process is more sensitive, so you can pick things up sooner. So we at the moment are using a laboratory in London at St George's Hospital, and this is actually David who's doing the analysis for us. But whilst there are pros, there are also cons, and so fortunately there are point of care systems available to measure both troponin and BMP. Very nice handheld system. Take the sample, inject it into the cartridge, and then push the cartridge into the machine. You'll get a value within 90 seconds to 2 minutes. 10 minutes? Your best systems are so good. Okay. Well, rapidly you're going to get a value. So this is the troponin cartridge here. One of the problems with the point of care assessment is that this is 10 to 15 pounds a cartridge, so it can be quite expensive. It's not unusual for the cartridges to be messed up, and so you might run a couple before you actually get a value. I certainly know that the troponin assay is not that sensitive, so it doesn't pick up the low values. So if you're getting a positive on a point of care Abaxis troponin, it's a high troponin. It's a very high troponin. But it's undoubtedly a very useful tool, but hasn't been validated in a population yet. Yes, it can be used, but it hasn't been validated yet. And so part of the project that we're doing is we're taking bloods and sending them to David, and ideally we'll also run them through the iStat system to allow us to compare and contrast. One thing that's, I think, really important to bear in mind when you're looking at cardiac biomarkers, know which assay has been used. So with troponin I, there's about a dozen different assays out there. All of those will be slightly different. So a troponin I on one assay doesn't equate to the same value on a different assay. So exactly as we were saying earlier on around standardization, make sure you know which system is being used. Ideally, you go and use the same lab if you're sending it to a lab, and know and develop a good relationship with the lab tech who's running the sample, because otherwise you can get some interesting results that might be a little bit confusing. But certainly a very interesting or a very useful addition to the overall assessment of cardiac structure and function and health in the Great Apes. Please. I don't know on BMP. Certainly talking with...
We talked about that, what she wants to demonstrate those packages in the history. We don't use our for cardiac biomarkers. We always well, I think it's the same. We don't seem to be saying that.
Yeah.
As you do, and with a vet is actually a problem. Most people here. So far we've had no positive.
Okay, that would suggest that you're on an old system. We can sort that, but it'll certainly compare across. The point of, I believe, and don't quote me on this, but I believe that the BMP assay on the Abaxis is better than the troponin. And that was a conversation I was having with Bombella over in Uganda. She was more comfortable with the BMP than she was with the troponin.
We were getting no troponin values from that, it was seen to be so.
Yeah. Okay. Probably just finish up with a few case studies. So I'm just going to remind you of this one. You've seen this one before. This is a healthy chimpanzee. We've seen all these. It's got nice EA, so you can see that the early filling is certainly dominant in terms of the diastolic function here. Remind you, we're looking for the walls to be uniform in thickness of the ventricle. We can see that during systole, the walls are moving in together in a uniform manner. There's no flicking of the valve leaflets. So all looks fine. Just wanted to remind you of what a nice one looks like. If we then move to a female chimpanzee who was undergoing just a routine health check, and this is what we saw. What jumps out? What's different with this one? Go on. Okay, so we've got some hypertrophy. Is there anything interesting about that hypertrophy? Is it a uniform hypertrophy? No. Okay. So if we were dealing with, say, hypertension, if there was blood pressure issue here, you might see a global hypertrophy, yeah? Thickening of all of the walls. We don't see that here. What we've got here is that the lateral wall is very, very thick. We also have a little bit of bulging here. Although that's a papillary muscle, there's a little bit of bulging here. And when you then come to the end mode, the short axis view, you can also see some abnormal thickening in this side of the ventricle. So it's an asymptomatic animal. Certainly looks to be abnormal, but we don't know. We don't have criteria at the moment. So whilst the thickness is non-uniform, that makes me slightly more concerned. The absolute values, I don't know what's normal. If we look at the ECG, there was a prolongation of the QT interval, probably reflective of that thickening of the heart. And when we go to the biomarkers, 0.03 for troponin is really on the borderline of normal in humans. And BNP, NT-proBNP, the normal in humans is around 100. So what we've got here is a picture, an emerging picture of an animal that appears to have some abnormal enlargement. We have a prolongation of the QT interval, and we have moderate elevations in the cardiac biomarkers. This was an asymptomatic animal. Is this the start of that fibrotic process? We don't know at this point in time. So this is an animal that will be routinely monitored to see what day it happens. Okay. This is a symptomatic chimpanzee. We've got a parasternal long axis view here. I think you can all agree with me that there's significant hypertrophy there. Yeah? If you look at the ratio of cavity diameter to wall thickness, the walls are really, really thick in comparison to that diameter of the ventricle. Prolonged QT and ECG evidence of LV hypertrophy. So here, the ECG would have told us that there was hypertrophy there. Without even doing an echo, we'd have seen from the ECG that there was hypertrophy. If we then look at the troponins and the BNP, these are very, very high values. Yeah, wasn't a good story for this chick. Okay, we looked at this echo earlier on. Remember, we looked at this regurgitation of the tricuspid valve. What will happen to the atria if we've got a lot of regurgitation? It will enlarge, yeah? So, where should we be looking on the ECG? P wave? So if we go to the P wave on the ECG, we've got a bifid P wave, and it's expanded. So again, knowing your ECG, this ECG would tell you that there is something going on with the atria. And then we look at the echo and we can confirm that there is a problem with the atria. So what I'm trying to show you here is how one tool can be used in isolation, or ideally together you get that confirmation of something underlying. Okay. So those are just some case studies of how the data is being used. What I now want to briefly move on to is some of the overall numbers that we're generating for the project and start to compare things. So these are a gorilla, chimpanzee, bonobo. I can't say anything more really than they grossly look the same. But I think with larger numbers, we might actually start seeing some differences in terms of the relationship between the cavities and the wall thicknesses. So what I have here is a measurement of left ventricular mass. It's a surrogate of overall heart size, if you like. And then we plotted that against body mass. We had gorillas, chimpanzees, and bonobos. We've got more data, but I haven't updated this slide as of yet. But what I find really, really interesting is that as we increase in body mass, unsurprisingly, the LV mass also increases. Big animals going to have a bigger heart. No real surprise there. Interestingly, the bonobos, the chimpanzees, and the gorillas fall on the same line. If, however, we compare that to human data, and these are it's data from a large number that we collected in the lab, the apes, the chimps, the gorillas, and the bonobos sit on a very different line to ours. So, for the same body mass, we have a much larger heart. Why this is, I don't know at the moment. It comes back to potentially what I was thinking about how we've evolved. But it's certainly interesting data that I want to follow up on. If we then look at the relationship between hypertrophy, and one way we measure this is looking at cavity dimension in relation to wall thickness. So if you have a thicker walls in comparison to your cavity, it's indicative of hypertrophy. In humans, we have a cutoff of 0.45. The chimps and the gorillas seem to be more along those lines. So whilst they have a smaller heart, it seems to be made up of thicker walls and smaller cavity. Overall, we have a larger heart, but their walls, relative to their cavity dimensions, are thicker. Again, don't know what this is. Is this the onset of that early onset of that fibrosis? At the moment, we certainly don't know. If we look at diastolic function, there also seems to be quite a bit of difference. And if we come back to that ECG of the gorillas having very little P wave and very little atrial contribution, it's unsurprising that the EA ratio is markedly different between the apes and us. Clearly, anesthesia is a problem in these comparisons, but I think it's certainly an interesting point to at least ponder as we progress. So, future directions, I've already talked through who we've been working with already. We're going to move towards the sanctuaries. Hopefully we'll start looking with the orangutan group as well. But we're also very interested to talk with other European collections, so hopefully that will progress over the next 12 months or so. And take-home message, I've already been through that, so you can now wake up and see the same slide again. And with that, I will just finish off and just thank people who've been intimately involved with the work we've been doing. Okay, thanks a lot.